Welcome to our video on atopic and contact dermatitis. Let's get started. In this lecture, we will go through atopic dermatitis, irritant contact dermatitis, and allergic contact dermatitis. And we'll start with atopic dermatitis. And for each of those types of dermatitis, we're going to cover the definition, etiology, pathophys, how it presents, and the diagnosis and management for each of them. So let's begin with the definition of atopic dermatitis. Atopic dermatitis, commonly known as eczema, can be defined as a chronic pruritic inflammation of the skin. It is frequently seen among children aged 3 to 6 months, and it can be associated with other atopic conditions such as asthma and allergic rhinitis. The etiology of atopic dermatitis can be multifactorial with a strong genetic predisposition. A mutation in the filaggrin gene leads to filaggrin deficiency, which further leads to impairment of the skin barrier. Now, some patients may develop increased levels of IgE, causing a type 1 hypersensitivity reaction. Now, most patients will actually have a family history that's positive for atopic conditions. Various triggers, such as climate, stress, food, skin irritants, and emotional factors, are also some responsible etiologies. Now let's talk about the pathophysiology. Filaggrin deficiency causes epidermal dysfunction. This leads to easy entry of the allergen through the disrupted skin barrier. In addition, the disrupted skin barrier also increases transepidermal water loss and loss of moisture, which is responsible for dry and itchy skin in atopic dermatitis. Patients usually present with severe pruritic rash with dry and scaly skin with crusted lesions. Lichenification and fissuring may be present. Common sites involved are flexural areas, the face, eyelids, and hands. Now, sites may differ depending on various age groups, and we'll discuss that on the next slide. Now, the Denny-Morgan fold refers to more pronounced infraorbital folds due to eyelid dermatitis. Now, disrupted skin barrier also increases the risk of secondary bacterial infections. Now let's briefly go through the sites that are involved in different age groups. Infants commonly present with lesions over the face, scalp, and extensor surfaces of the body. Children older than 2 years old present with lesions over their flexural areas of the body, such as the elbows, knees, wrists, and ankles. Adults might also present with lesions over flexural surfaces. Now, some patients present with localized hand eczema provoked by irritants. This is a case of atopic dermatitis in a 2-month-old infant with dry, inflamed, and flaky skin over the face, scalp, neck, and even the upper chest. Notice the increased creasing over the infraorbital region, and that's a manifestation of eyelid dermatitis. And these folds are referred to as Denny-Morgan folds. And here's a picture of flexural surfaces of the knees over the popliteal fossa, and this shows dryness and lichenification due to the persistent scratching. Diagnosis of atopic dermatitis is based on history and clinical findings, and the diagnosis is suggested by the presence of itchy skin along with 3 or more of the following features: history of skin crease involvement, personal or family history of atopic disease like asthma or hay fever, presence of dry skin within 1 year, and 4, visible dermatitis involving the flexural areas. Management of atopic dermatitis is aimed at prevention and treatment. Now, triggers should be identified and avoided. Aggressive use of skin emollients maintains adequate skin hydration. And finally, hot showers should actually be limited in order to avoid skin dryness. Antihistamines are given to relieve the pruritus. Now, topical corticosteroids, such as fluocinolone, betamethasone, and triamcinolone, are the first-line treatment options for atopic dermatitis. Now, topical calcineurin inhibitors, such as tacrolimus, are used as steroid-sparing agents, but the idea is to actually go for the steroid. Now, phototherapy and systemic therapy should also be used in the case of diffuse pruritus that is refractory to medications, such as the antihistamines which you would have prescribed. How can a physician determine clinically if a patient has seborrheic dermatitis or atopic dermatitis? We know that atopic dermatitis is a dry, scaly skin rash with crusted lesions and is generally over flexural areas and the face and eyelids and hands. The diaper region is usually spared in atopic dermatitis. It is also associated with asthma or a positive family history of atopic conditions with environmental triggers. Now, seborrheic dermatitis is an oily, yellow, crusty rash frequently on the scalp in infants, though it can involve many areas including the face, chest, and diaper regions. So that environmental history and the family history and the location of it can really help you distinguish these two. Not to mention that they appear a little different. For example, that oily, yellow, crusty idea of the seborrheic dermatitis. Now let's talk about contact dermatitis. Before we dive into the individual types of contact dermatitis, I want you to have this general introductory idea. So contact dermatitis is the inflammation of dermal and epidermal skin layers as a result of contact with an allergen or irritant substance. It can be further divided into irritant and allergic contact dermatitis. So we'll actually start with irritant contact dermatitis. Irritant contact dermatitis can be defined as a localized skin inflammation in response to physical or chemical agents. It begins soon after exposure to irritants and is non-immune mediated, and it's more common than allergic contact dermatitis. The common irritants include soaps, detergents, oxidizing agents like sodium hypochlorite, acids, alkalis, wood, metal, and dust. The pathophysiology begins after exposure to the irritants, and the epidermal barrier gets disrupted, which then increases skin permeability, and that increases transepidermal water loss and loss of moisture. Patients usually present with an erythematous rash, which may be accompanied by burning pain. Now, fissures or small cracks can also be seen. Now, irritant contact dermatitis is less pruritic than the allergic kind, and the commonly involved sites are the hands, fingertips, and the face. Here's an example of irritant contact dermatitis caused by the application of a bandage over a wound. Now, this picture shows an erythematous scaly lesion. Here's another case of irritant contact dermatitis, showing localized erythematous rash over the palm that resulted due to contact with damp construction debris. The diagnosis of irritant contact dermatitis is primarily based on history and clinical findings. The patch test is done to rule out allergic contact dermatitis, and a skin biopsy is done to rule out other conditions. Management is aimed at controlling and improving the condition by identifying and avoiding triggers, as well as treating active inflammation and restoring the disrupted epidermal barrier. And topical corticosteroids, along with allergen avoidance, is considered the best initial therapy. Now, commonly used topical corticosteroids include clobetasol propionate and betamethasone. Moisturizers and emollients should be used to decrease that irritation of the skin and maintain hydration of the skin. What predisposing factors could a patient with irritant contact dermatitis have? Now, irritant contact dermatitis is more likely in a person who has either increased exposure to potential irritants, a decreased epithelial barrier, or reactivity of the skin is highest in infants and then it decreases with age. And those with atopic dermatitis are at increased risk due to their chronically impaired barrier, which increases the susceptibility to irritants. Now, increased exposure to irritants would come secondary to occupation or household duties as well as the environment. Areas with high temperatures and airflow decrease the functionality of the skin barrier, leading to increased penetration of the irritants. Cold temperatures with low humidity increase the amount of water lost through the skin, also increasing susceptibility. So basically, in extreme climatic conditions, there is an increase in the person's susceptibility of irritant contact dermatitis. Finally, let's move on to allergic contact dermatitis. So this is defined as an inflammation of the skin due to a type 4 hypersensitivity reaction in response to various allergens, and the rash occurs 1 to 2 weeks after the exposure to the allergen. Some common allergens include poison ivy, poison oak, or poison sumac, metals like nickel and cobalt, soaps, detergents, latex, and drugs such as neomycin and benzocaine. Let's discuss the pathophys. So, an antigen or an allergen penetrates the skin, sensitizing the T cells, and repeated contact with the antigen leads to secretion of cytokines by the pre-sensitized T cells. And patients present with intensely pruritic erythematous papules and a vesicular rash over the exposed sites. And the chronic stage is characterized by crusting and lichenification of the skin. Here's a case of allergic contact dermatitis in a 3-year-old girl with vesicles over her left leg, and that appeared after contact with poison ivy. All right, let's do a question to apply what you've learned so far. A 25-year-old man presents to the clinic complaining of an itchy rash on his forearm. The rash is pictured in the image below. He noticed a red blistering rash this morning and does not recall having it in the past. He went for a walk in the forest with his friends 2 days ago. On examination, the rash is erythematous with vesicles and papules. His temperature is 36.5 degrees Celsius. Heart rate is 68 beats per minute. Blood pressure is 120/80, and respiratory rate is 15 breaths per minute. What is the most likely diagnosis? Okay. The description and image indicate this patient has an erythematous vesicular linear rash. Now, this rash appeared after the patient went on a walk in the forest, indicating that he likely came into contact with poison ivy. Therefore, the most likely diagnosis is allergic contact dermatitis. Now, the diagnosis of allergic contact dermatitis is also made on the basis of history and clinical findings. Patch test can be done to identify specific allergens. Finally, in treating allergic contact dermatitis, allergens should be identified and, of course, avoided. Now, mild or soap-free cleansers and moisturizers or barrier creams should be applied. Now, topical or systemic antihistamines can be given for the pruritus, and topical corticosteroids and topical calcineurin inhibitors are used for mild to moderate cases. And lastly, systemic corticosteroids are used only for severe cases. Now let's wrap up with a board-style question. A 21-year-old female presents to the clinic complaining of an abdominal rash. She noticed this a few months ago, and it seems to come and go. And it's associated with a burning pain, but not too itchy. She reports being an avid cross-country runner and has no medical problems. On examination, there is a small, well-demarcated erythematous rash just below the umbilicus. There are no other erythematous areas. Her temperature is 36.5 degrees Celsius, heart rate is 54 beats per minute, blood pressure is 108/60, and respiratory rate is 15 breaths per minute. What is the pathophysiology of the most likely diagnosis? A. Chronic pruritic inflammation of the skin. D. Disruption of the epidermal layer from a chemical or physical irritant. C. Reactivation of an endogenous virus. Or D. Type 4 hypersensitivity reaction. Okay, so the patient has an erythematous rash that is well demarcated and accompanied by a burning pain sensation, but no pruritus. And the rash is also localized to a small section just below the umbilicus, which is where people button their pants. Now, metal buttons may cause irritation of the skin and rash over the area of the contact. So contact dermatitis from an irritant is actually the most likely diagnosis. Now recall that what causes this is a disruption of the epidermal layer from a chemical or physical irritant. So B is the correct answer. All right, let's go over the incorrect answer choices. A is describing atopic dermatitis, which is more likely to present on flexor surfaces, eyelids, or hands. It is also unusual to have the first presentation at 20 years of age with a limited skin area involvement. So A is incorrect. Now C is incorrect because reactivation of an endogenous virus happens in herpes zoster, which may present with a burning pain, but you'd see it in a dermatomal distribution. And D was likely a tempting answer because it's describing allergic contact dermatitis, and being a cross-country runner raises the chance of exposure to sumac plants, though we'd expect the rash to be more like on the arms or legs, not just beneath the umbilicus. Now, allergic contact dermatitis usually presents as an itchy vesicular rash. So, again, D is incorrect. And that concludes this section.